Hey folks, we are back. It is now time for Ask the Doc with Dr. William Whaley, Ray Tidman, and Leo.
Well, you were saying you had to cut the humidity and it was hot.
Wow.
It's 66 degrees and it's cool out here because it is humid. Now, I'm not saying it's going to be at 2 o'clock in the afternoon, but it's perfect this morning.
Do we want to get into medical reasons of why I'm sweating like this?
We don't want to we don't want your mama to know.
I didn't bring my thermometer.
Okay.
No, and I'm not sweating and he's not sweating. There must be an obvious reason there.
Thank you.
All
Thank
right.
you, Georgia Cancer Specialist affiliated with Northside Cancer Center for this segment every week. Dr. William Whaley and Dr. Raymond Tidman, we appreciate it. We have our All-American, the red, white, and blue, the stars, the stripes.
As there are. You said here there's 9 flags you can see
Yes,
from sitting
that's-
there. Consider this my announcement to the local community. I am running for City Council Post 4. If you live anywhere around here, you got friends and neighbors that live in Blue Ridge, you know me, tell them to vote for me. So I picked this out on Tuesday to wear today. But what happened yesterday in Afghanistan, I would have worn it anyway. I want to explain to you, everybody kept saying 12 Marines and a Navy one. The issue is, the issue for the Marine Corps is that they have no medical their own. Their medics and their doctors are provided by the Navy. So a squad of Marines, you can't tell them, the Navy guys are all wearing Marine Corps uniforms. I wore Marine Corps uniforms the whole time I was with the reserves, is a 12 infantrymen and 1 Navy corpsman. So that's the Navy guy. He was a corpsman. So when they say a Navy guy, people think of a white hat and bell-bottom pants coming off a ship. They are Marines. They're trained in the Marines. They go to Marine Corps boot camp, but they are part of the Navy, and their paycheck comes from the Marine Corps, but they're part of the Navy. So that it was a Marine in a Navy uniform.
And they stopped the bleeding and they stopped the pain.
They stopped the bleeding and they put in the chest tubes and do all that stuff on the battlefield. So, and in Vietnam, during the period I was there, 67, 68, a Navy corpsman that came ashore in that period of Tet, there were 4, that 1 would be killed, 2 would be wounded, and only 1 would finish out his tour of 13 months and a day. So they had 1 out of 4 would get out of there without being dead or wounded, and they are the most vulnerable on the battlefield, even more so than the Marine, because they're running into the shooting to pull somebody out. So when they talk about 12 Marines and a Navy guy, they're talking about 12 Marines and a hero. So let's get off of that. It makes me cry.
No, I understand. I understand what you're saying. I was just repeating what they're,
I'm
reading.
Appalled. I'm appalled at what happened there. I've been in a war, and I have not heard a single veteran who is not insulted by the situation. And we're going to talk about double hit lymphoma.
Got it. Well, thank you very much. I think no matter what segment we're doing today, we're all affected by this, and all concerned, and our hearts go out to those families that are getting the knock on the door. So
I made 1 casualty call in my active duty time, meaning I got in the car with a chaplain and a Navy medical officer. A Navy lineman. I was a medical officer. Well, we knew that the woman had psychiatric issues that they were going to, and a chaplain. So I made 1 call. They aren't fun. You go in a car. You don't make a telephone call. As they said, people are going to get phone calls telling them that that's not going to happen. No matter where they are, that's going to be delivered in person by a senior enlisted or an officer in uniform, and there'll be a chaplain with him.
When every mom and dad, there's a couple words that are really big, and every is a big word. Every mom and dad, when their son or daughter enlists in the military, just never want that knock on the door and look outside and see somebody in their uniform.
Yeah,
that's
you remember in Saving Private Ryan, you can see that long car come up the driveway. It starts way out there on a dirt road, and the mama looks out the window and notices it's a military car. Anyway, let's get off of that. You want to hear about double hit lymphoma?
Yes, I'm sorry to continue it, folks. Again, Ask the Doc here, Dr. William Whaley and Dr. Raymond Tidman, and our first question of the day.
All right, our first question of the day is focused on Brian, the first word in the question. Brian has mentioned double hit lymphoma several times on your program. Actually, it was last week was the last time. And said that his mother went in too and has stayed in remission.
We're over a year now.
Okay,
Yes,
over a year. My brother in Atlanta is very healthy and 67 years old and just finished R-CHOP for 6 treatments and is in a partial but not complete remission. That's the difference to your mother.
Right.
Your mother was in a complete remission at the end of 4, I think, and they gave her 2 more to consolidate it, and
Yes.
then the PET was negative, correct?
Right.
All right. The oncologist and the lymphoma leukemia bone marrow transplant team. That tells me 2 things. This patient's either at Emory or at Northside, because this question came from Atlanta. All agree he needs a few cycles of a new chemo and then a transplant. What do you think, and why would he have not reached a remission? You got that?
Yes.
Okay, so we're talking about, and I'm glad that we're doing this long after your mother had this, because I did talk with you during your mother's
Yes.
disease, and I was always encouraging.
Yes.
And I never showed you any of these numbers. So now you're going to see these numbers yourself for the first time. Put up the first one there. Double hit lymphoma means that there's 2 separate genetic modifications in that tumor that have bad outcomes. Most of them have none of these hits. So most diffuse large cell lymphomas are 0 hits, single hit, no hits.
Right.
There's a single hit and then there's a double hit. Okay, you got that up there? But the last line, I want you to just read that. Treatment induction regimen does not impact the progression-free or overall survival. And it gives you a big old name here. This has got the highest response rates, but it's the most toxic. So that CHOP-R that your mother got is the standard of care.
Right.
All right, put up the next one. Now you remember we stage things, right, Ray? A little bit here, that's stage 1. If it's in if it's all over your body, all double hit lymphomas are stage 4, meaning that they are by definition diagnosed as extremely aggressive and extremely high stage. You got that one? You can pull it down. You're going to get 2 of these on this one question, okay? We always got to have a survival curve, for BKP. The first one is the survival hit in double expressor diffuse large cell lymphoma versus, so that's no hits, single hits, double hits. You don't need to know the time progression down here, but that's years. And you can quickly see that from the top, which is regular lymphoma, single hit, double hit, it goes way down. Put the next one up there. We're going to have this one, we're just going to show it and then pull it back down. These numbers, and this goes on forever. That's why I said I'd give you 2 of these. But this, first thing I read you, event-free survival, progression-free survival, and the bottom was overall survival. You can pull that down now. Statistics are different. You know, you're interested in overall survival, right?
Right.
How long are you going to live? Progression-free survival means that you did not get a progression, and if you got a progression, you can bring some of those, you can cure some of those, right? So then the overall survival goes up. So that's why those terms, overall survival, progression-free survival, and event-free survival, all mean different things. What you're really interested about is what's overall survival going to be, because progression, you get progression, you can pull it back. Event means, anyway, so that's good. So here's what I'm going to tell you. Your brother has not relapsed. He has failed to enter a remission with first treatment. So those 2 things are different. If Brian's mother were to relapse now, a year out, which would be unusual, it would be a relapse. If she had had a positive PET scan at the end of 6 cycles, that would be a non-remission. They're
Right.
both different. Okay. The non-remission must then get aggressive therapy, but needs to have the degree of disease diminished. So they're going to put your brother on additional treatment. When he gets to that point, there are really two options. The fact that they have mentioned a transplant goes back to the first part of your question where you said he's in excellent health. So he's strong enough to undergo a transplant, and that is that means that they'll get rid of the disease with this new treatment. It'll probably last about 2 months. They'll bring him in the hospital. They'll give him a high-dose chemotherapy. They'll salvage his, before they bring him in, they'll give him some medicine to stimulate his white cell growth. They'll pull that out. That's his stem cells. They'll put him in. They'll give him a big dose of chemotherapy to drop his blood count. They'll give him his own blood back. His stem cells will pick up, and he'll be in there 2 weeks to 4 weeks, and then he has a much greater chance of entering that overall survival group. So show that next one. We're just going to go through this kind of...
While he's pulling that up, so how far into his treatment will they go before they decide he's failing to respond?
When
they start his therapy.
Okay, the first therapy he got. Okay, first therapy, if they've gotten to 6, that's it. They stop there because the toxicity of those drugs includes adriamycin.
Okay.
And so you got a limit to how much of that you can get.
Okay.
You know, if it was penicillin or something, you'd say, well, there's not really a limit, except if you keep giving it, you might get bowel overgrowth. So everything we got's got a limit,
so
right?
They're going to max out one of the agents.
You're going to max out one of the agents, 6 cycles.
resurvey.
If it hadn't done it, statistically, it's not going to work. Go to something else. Okay, this first graphic here is about stem cells. So what they do is they take out your own, we've done this before, but they take out your own white cells. They're yours. You can pull that back down a minute. Ray has some grandchildren, and I have 7 grandchildren. And in one particular family, the 3 grandchildren, I have paid to store their cord blood frozen forever, so that if they ever have a disease, they've got their own they got their own cord blood from the time they were born, when that's just all stem cells. They don't have to go through any of the rest of this. And their parents, if they have a trouble, they got their 3 kids' stem cells, which should be great matches. So that's something we've never talked about here before, but you can, if you have the means, you can store your grandchildren or your children's cord blood frozen in an institution that'll stay there for 100 years, assume it pay the rent every 10 years. And then if a family member has a problem, that cord blood's there. All right, so pull that one down. The one thing we didn't talk about, and it's come up here before, it's been that this patient has another option, and that is, if, for example, if he doesn't stimulate enough stem cells, which isn't going to happen because he's in good health, but CAR T therapy. Remember, put up that next one. We'll just briefly look at it. CAR T therapy costs a couple $100,000 a month, and it goes on for several months. And what that is engineered T cells. So everything we talked about before is B cells, but CAR T therapy, you can pull that down. It has a very high success rate in leukemias and lymphomas. It's only available at Northside Comprehensive Cancer Center. It's available at Emory, but it's only going to be available in a place that's got bone marrow transplant type high-tech treatment. So at the end of the day, the question asks, what is my thinking? And my thinking is, your brother's getting great treatment. He is in that group that failed to respond. So in those survival charts, he hasn't reached remission yet. So this is not an event after treatment. It's not progression after treatment. So those curves don't apply to him. And so if he takes this treatment, gets his transplant, he has a very good chance of staying on those upper curves. If he does not respond to this treatment, he has the option of CAR T treatment, and therefore stick with it. It's going to be probably 2 to 4 months more aggressive therapy. You got it?
Because this person mentioned myself, I just want to say, until my mother, I really, when people have they had cancer or went through this, I couldn't really say I understand how you feel, I understand what you're going through. I really did not know that. But I do understand what you're going through. I understand the meetings you're having with the doctor. I mean, I lived on a flight to Pennsylvania and back. I stayed almost 2 weeks every month. I would go, my mom would have the R-CHOP, and then it's like, we'll call it the crash. It was about like 6 to 8 days after that when she got home, when she would crash. So I would make sure I was there to try to help take care of her. My mother ended up 3 times in the hospital. I mean, back in.
Yeah.
And really, it was a struggle.
And how old was she?
I think she was 76. I think
Yeah,
76.
right. She was a fragile. Right. She was fine china.
Yes, and on top of that, two times we had to do blood transfusions.
Yeah, that's common.
Yeah, she had to have blood, but when you're sitting there and the doctor's saying, well, we have to see if it's gotten in the bone, and all the things you're hearing, I understand. So I know it's tough. I know it's tough on your brother and your family, but as Dr. Whaley said, it sounds like they're at the right place.
They're in the right place. They're getting the right kind of treatment.
Because I want to tell you, while I have them, is although my mom's in Pennsylvania, if she had a great team of doctors, I would call you and say, here's our doctors, here's what we're being told, this is what's going on, and you would say they're following the procedures.
I actually talked to the doctor.
Yeah, you actually exactly
talked to that doctor.
So anyhow,
so you would rather have him reached a remission in 6 cycles. But the number that do that is down around a half, which we never did tell you. I kept that from you. And going forward, the right thing to do. All right, our next question here is really a PCP question, because this is a question that begins with alert or not alert at the primary care level. My husband has had a PSA of below 4 always. Now, we did not get an age here, but the guy's clearly over 50 because he's been having PSAs, and always sounds like it goes back a number of years. But in May, it had changed from 1.5 to 3.8 in 1 year. Now, both those are normal, right? And you would see that with prostatitis or infection. You might see that if the guy was a bike rider and had been riding the bike the day before he got his blood drawn, because lots of things will raise your PSA dramatically. Got nothing to do with cancer. And his PCP sent him to a urologist. Well, I'm real happy about that. He was biopsied and was Gleason 8, whatever that means. Well, you'll know that from prior exams. Gleason 8 is a pretty aggressive, high-grade prostate cancer. He had a normal bone scan and an MRI. Now, I know that this patient, the woman who writes this question must be an internet person, because most people don't really realize that there's PET scanning that's special for prostate. So we asked for a PET scan and his insurance didn't allow it. There is a special type of PET scan for prostate cancer that many insurance companies will not allow unless the MRI or the CT scan show that the lymph node's enlarged, and he had an MRI and therefore it must not have been enlarged. So we went to surgery last Friday. That was actually not this Friday, but the Friday before when I got this question. The robot urologist, so a separate robot surgeon was doing his surgery, opened him up. The lymph nodes looked bad. He biopsied them and they were cancer, and he did not remove the prostate, closed him up. Sound reasonable?
Yeah.
Sounds reasonable. Actually, that guy's probably a really good surgeon, because a lot of them would have gone ahead and taken the prostate out. Then the guy would have had 6 weeks of delayed recovery before he could do something else. He'll be up and around the next day. He has suggested hormones and radiation and no surgery. We would still like a PET scan. What do you think? So I'm going to answer this question and leave the PET scan until I get to the end of it, because this is first of all, I want to stick to the PCP guy first. Okay, Ray. The prevalence of benign, let's put up that first one over there, will you? The prevalence of benign prostatic hyperplasia pathology with age. So this is non-malignant pathology. What's that age group right there?
41 to 50.
My gosh, that thing goes up like a rocket, doesn't it?
Yeah.
What's the
So
top
that
of the
must-
scale?
That must be why they start doing blood tests at 50, right? So by the time you get to 80 or 90 years old, almost 100% of people have pathology within the prostate. And I've said this before, at the Armed Forces Institute of Pathology, they have prostates in storage that go to the Civil War. Hearts that go to the Civil War, and that's how they can tell you that as years have gone by, heart disease goes younger, because weights went higher, fat went higher, refrigeration went higher, but they've got veterans that are 100 years old that have been autopsied at the VA, and they got their prostates. So if they just start looking at 18-year-old people killed in battle and then 100-year-old veterans who die, as they begin to get older, get above about 70, there's cancer in many of those prostate glands that's a very low grade. That's a grade 6 or a grade 5. Grade 8, you're sick. All right, so that's the first one. Second one, get the next one out here. This has to do with how rapidly your PSA rises. So I think most PCPs don't really focus on the rate of change from last year to this year. You can pull that down now if it's still below 4.
Which is bad thinking.
That's bad thinking. That's my point.
That graph, by the way, is a logarithmic graph, so that's why that line is straight.
Whatever that means. Okay. So the point is that this guy's PCP was on the ball, right? Okay, so you just graph up that next one. Any lymph node positive is you're the highest grade you can be. So it doesn't have to have spread to your bones to put you at the highest level if a lymph node is positive.
It means it's out of the shell of the prostate.
It's out of the shell of the prostate and in the lymph node. Pull
Bill,
that one down.
can I interrupt you one
well, of course,
quickly?
you're supposed to. That's your job here.
Your point about the primary care physician doing his job is well said. The other thing is that this is something men do. Men should be getting their PSAs done, and they should be keeping track of those numbers. And
They themselves.
And if those numbers are accelerating up, and they're getting a shrug of the shoulders, get a second opinion.
Yeah, that's a good point. Second thing is people move around so much.
Yeah.
Insurance plan changed. They had to go get another doctor in another network, and the other doctor in another network doesn't go back and get last year's PSA. It's actually your responsibility to remember it and to bring your records to that guy, then hope he focuses on it. All right, go get your PSA and get your digital rectal exam. Put up this next one. We're going to talk briefly about the radiation therapy. There are 15 kinds of radiation therapy and local control treatment, and there are advantages to every one. Now, the advantage to this radical prostatectomy, which they were getting ready to do to him, instead of the old-style prostatectomy, we won't go into today, but there are 2 ways. Pull that one down. There are 2 ways you can do this radiation. You can put seeds in there, or you can give external beam radiation therapy. This man has lymph nodes. I'm going to recommend that he get external beam radiation therapy. He's got Gleason 8 disease. They come back and focus some extra radiation on his prostate itself. Pull that one down. He's got to have that hormone therapy that they mentioned. Anybody with that degree, we talked about that a million times here. So here's the simple thing. Got a picture of this guy lying there. To get him on radiation therapy, he'll have to see a physicist, see a radiation oncologist. It'll take 2 weeks for the physicist down at Georgia Tech to figure out how to do the shoot. And pull that one down. That radiation therapy is going to be delivered high intensity right there to the gland, and they're going to move that machine around. I don't understand it, Ray does, but they're going to focus that radiation through 360 degrees so it doesn't burn the skin, and it all focuses in the middle. Is that about right?
That's a good way. And they're going to dodge certain critical other organs in that area.
But that's going to be done by a rocket scientist, physicist that went to Georgia Tech.
With a slide rule.
The slide rule. All right, this is the last one. I think the man needs a PET scan.
Yeah. Yeah.
And then if the insurance company is not going to pay for it, I think they'll pay for it this time, then somebody needs to argue about it. Throw this thing up here. This is a beautiful picture. There are some pretty beautiful colors, aren't they? But you see these little hot spots here. We don't see the colors here. These little hot spots could very well be there. The bone scan was negative, so they aren't in the bones. But these hot spots that sit around here and lymph nodes outside of the immediate field, he may have lymph nodes that are not right there that would be covered by radiation, in which case the cat's out of the bag and he needs more aggressive treatment. So pull that down. At the end of the day, then, my thought is, yes, I hope they'll pay for it. 2, he is, from my way of thinking, he's probably in his 60s or 70s, aggressively treated, appropriately radiated, and given hormonal therapy. Unless his parents all live to 100, this is not going to take him out, but it's going to be a constant treatment for the rest of his life with hormones and monitoring there.
This is an interesting incidental question. You've got a few years on me, but when I was in medical school, it was very common for men to be ravished with prostate cancer. It was just something we saw. We saw in the hospital that came in. Nowadays, I hardly ever see it.
Right. Yep.
And Bill, would you comment on that? How much more success we have in this country at identifying and treating?
Well, first of all, I think that's got to do with doing PSAs.
Yeah.
And making the diagnosis. But we have learned so much about the genetics. As a matter of fact, now anybody who has advanced prostate cancer or high grade should get a genetic test of their tumor at the time of diagnosis, because we have treatments in addition to surgery, radiation, hormonal therapy, or chemotherapy that are strictly genetically driven. So that's what has turned this around. You still see people dying of prostate cancer.
Yeah.
But the incidence of people that are sallow complected, look like they've lost 100 pounds and are in bone pain all the time, we just don't hardly see it. Yeah. All right, so that's that one.
Thank you, Georgia cancer specialist affiliated with Northside Cancer Center, for this segment and these questions every week. We appreciate your questions, and we thank Dr. Whaley for going through in great detail to answer your questions out there.
Great detail. That'll make my wife mad. That's okay.
Well, I mean, no.
Yes, Dr. Whaley, what time it is, he'll tell you how to build a watch. All right, I hear you.
I would rather, if I'm sitting out there and I asked you the question, I think the reason people ask you questions is they know you're going to dig into it throughout the week. You're going to bring them the details, and you're not just going to give them, a 2-minute answer and go see your doctor after that.
All right,
go see your doctor.
All right. Well, we got important stuff here, and Dr. Tidman is the expert on this, because he came in this morning with some information he's going to share with you just a minute. But we got to look at the percent positive in the last week. What's the number?
16.8.
All right. You'll remember that the week of July the 4th, it was 1.4.
Right.
Anything under 5 is good control of COVID. But what was this last week? 19, right. 19.6. All right, now, the next question is, how many deaths were there in Fannin County due to COVID last week?
76?
4.
Okay.
And it's been holding there.
How many are there now?
74?
6. So we've had 2 deaths this week.
Okay. That's where I got the 76.
Okay, you saw me writing it down when you came up and put the thing in this morning.
They don't need to
You
know
cheated,
that.
didn't you? All right, so the COVID peak of the fall of the spring of 2020, when the mask mandates shut down the restaurants began and all the restaurants closed, that peak, I was going to show it to you, but I don't have it where they can see it. That peak is about 1/3 lower than the peak we're having now, meaning that the original mandates to shut down the world, COVID was not as prevalent as it is today. So why is the world not shut down? Well, first of all, I know that Governor Kemp and Speaker Ralston and our state government is doing everything in its power to keep this state open and functioning, and they're resisting the feds, they're resisting the CDC, and they're resisting the world that's falling, your hair's on fire, people. they want you to be careful. They want the fine china to take care of the fine china. They want you to go about your business. And if you go someplace where there's going to be a bunch of people, put your mask on. But
and
they're
Bill,
keeping it open.
They're keeping it open, and let me model something here. We talk about diseases, and we talk about risk and hazards, benefits and hazards. You always compare. Okay,
Right.
What is your treatment? What is the complication of the treatment? What is the complication of no treatment? Every disease we do that. When this thing came out, everything was about treatment, no hazard. Now we're learning, people are stopping, the public health people are finally pushing back and saying there's a side effect of shutting down. There's a side effect of keeping children out of school. There's a side effect of putting diapers on children's faces. And they're comparing the two, and they're being more open-minded and I hope wiser about how we do these things.
Go back to the suicide thing,
Yeah,
because you
yeah.
weren't here the week.
Yeah.
The suicides in children under the age of 16 is up by, I think it's 210%. It was 170% a couple of months ago. It's still going up.
Yeah.
So these are adolescents, young people down to probably 12 or even younger, that are ending their lives because it's been screwed
They feel
up.
so helpless.
Yeah, they're so helpless. Now, there's lots of others. Their husbands are beating their wives, and
Yeah.
people are staying home drinking adult beverages and stuff.
Yeah.
But these are side effects that got nothing to do being hospitalized or having the COVID. It's the spillover
treatment.
effect.
Right.
Okay, I'm just sitting there waiting for you to talk about Germany now.
Well, the breaking news, Germany's 6 hours ahead of us. The health minister of Germany has come out and announced today that Germany will not be vaccinating anyone going forward. They're stopping all vaccinations for safety reasons, and they're going to review them.
Well,
They're
they're going to stop the vaccinations because of uncertainty.
Uncertainty.
And they're going to investigate
It's
the
going
safety.
to investigate
Yeah,
the safety.
okay.
I don't want to say that they've reached any conclusion, but they've put their hand up and said, now wait a minute, there's some data here we need to look at.
Right, and they have a high vaccination rate.
Very high vaccination rate.
They've got 70 or whatever they were after
Right.
in the first place.
Right.
So I think there's two things about that. One, we don't have 70,
Right.
but they do. So I think that it's a little safer for them to shut down than it might be for some country that's got 30%. But I think you're right about this. So go
Right.
ahead.
And then the other piece that their health minister said is that they are downgrading COVID as a killer from the god-awful Godzilla-bacter thing that it came out with a year and a half ago
You mean like-
this is a disease.
Like Ebola or something.
Yeah, this is not Ebola that kills everybody. This is a disease. It's clearly a disease. It's out there, but it's not something that we need to be running and hiding over. And I think that's very important, because Bill and I have stressed repeatedly that people need to go on with their lives, and they need to learn about how to take care of themselves and how to avoid the virus. But for heaven's sakes, do not panic. Do not shut yourself down. Do not shut your families down. Do not fail to meet and be with your loved ones. This is an important part of our lives.
Well, let me say this. As you well know, the 515 corridor here, and our sports department, big in sports in North Georgia. Last Friday, in Gilmer County, the football game was canceled. Okay. And
Which team canceled it?
I'm not for sure, and that was canceled against Pickens. Now this week, there's four high school football games canceled.
In North Georgia.
Union is canceled. Let me think. Who else? Let's see. Union is canceled. Fannin is canceled. Fannin is supposed to play Basin. That's canceled. Union, there's 4 games right now canceled.
Well, let me show you why that might be. Look at this right here, just a minute. See, what's that? What's the top line there? What color is it?
Red.
Okay, that top line, that's the number of cases going all the way back to last year in March.
Right.
That age group is 30 years old to 50
Right.
years old. If you look at the 18 to 29 down there, that yellow one is pretty much below that, but it is actually above the number that's over age 60.
Right.
And now what does that say? That's positive tests. That ain't people in the hospital. Now the
Right.
deaths, I got a death chart there that shows people are dying of this disease down to about 28, 30 years old. But what that says is that when the and I've said this about my grandson, and I wanted to get immunized because he's a college quality kicker.
Yeah.
In his school, if he wandered by somebody that was COVID positive, they were going to put him in a 10 or 14 day quarantine. He wouldn't kick. Then scouts can't see him, so he got the vaccine so that if he gets near somebody, they'll let him still kick. Other than that, I don't see why you need to go vaccinate those people and why you need to cancel these games.
Well,
doesn't
and
make sense
we
to
don't.
me.
But I mean, I want to
Playing
be
outdoors.
They're playing outdoors. It's outdoor activities. My motto all along has been stay alive, go outside. But at the same time, I don't want to be too harsh on the school officials. At least in this area, they seem to be being more respectful of people's lives. And it may be that coaches are out, or that there's so many kids that are out with flu-like symptoms that they can't put a team together. So
there are multiple reasons. You're right.
Right. So I'll agree with that.
Yeah.
I'll agree with that. But I do in the let's say in the not argument. Well, in the back and forth concerning vaccines, vaccinated, unvaccinated, I hear more people being actually upset with the mask.
Well, there is, and I'm glad you brought that up, because I really want to put a nail in this coffin. Okay, mask.
You're not going to be able to, but you can
I'm not
try.
going to be able to, but I'll give it my best shot. Okay, another study came out, from the engineering world. Imagine that, where they looked at the different kinds of masks, including N95 fitted to your face,
Right.
and they pushed air through them. Okay, and you have to understand that the virus travels on moisture particles. Okay?
Yes.
If they're exposed to dry air,
virus, yeah. People that places.
The virus doesn't travel. If the virus is exposed to dry air, it dies. Okay, so it has to be in moist droplets to get out. So when we sneeze or cough, that's when we're pushing those droplets out. When you look at a human breath at a human velocity and volume going through that mask, it stops 10% of those particles. Stops 10%. 90% are getting through. Okay, mechanically the mask cannot work. There are no studies, no randomized studies anywhere in the world that show that they work. There are no demographic studies even in the CDC's database that shows where one region heavily masked, another region didn't mask, that shows that they make a difference. They affect children's learning, and children cannot wear them right. I call them face diapers on children. Get the face diapers off the children. If an adult feels like they're safer with the mask on,
Wear it.
Wear it. Okay? I want you to feel safe. But to think that piece of cloth or paper or whatever it is on your face is protecting you is nonsense. Okay? You need to establish good health, good relationships with your doctors, and you need to know how to get to someone if you have symptoms. You need to test and figure out, do you have symptoms? You need to self-isolate. You need to protect yourself. You need to ask for treatments. The masks are complete and total distraction. I'd rather you wear garlic around your neck.
Well, that's pretty good. Garlic does get the haints away.
Oh, yeah.
I had a lady work for me. There was a housekeeper for me in 1946 that wore garlic. Now, she had an acidity bag.
Okay,
around
wait a
her
minute.
neck.
Where
Wait
did this go?
Acidity bag. Okay, now I want to just get back to this a minute. I watched these Netflix series when I'm on my bike,
Yeah.
and a lot of them come from Norway and Sweden, and they're kind of interesting. But if you'll notice, when they talk, because it's cold, you got that puff of air that you see that turns foggy looking when you speak. Okay, you see how far out that goes on those TV programs? Yeah. That is a droplet of moisture in just speaking, okay? And that thing goes 6 feet, and it depends on how cold it is, but you'll see it on any one of those programs. So when we're just talking like this, there's this big cloud out there. So those droplets can carry this virus.
But my point is the mask is not going to protect
you.
And
I
you
understand.
put 50 people in a church, and they're all singing, and there's no circulation in that air.
They're going to get COVID.
The masks do nothing. They're going to spread the COVID around, okay? So I'd rather you have outside church and take the mask off. That's what I'm pointing out here. Don't think something that don't work works. To put that in country language, okay?
Right. We had an event in a county, and I watched this. We had an event in a county. I was told the number I was given was 12 that tested positive, But the next thing I knew, the next thing I find out is the 12 had turned into the full county. I mean, it ran through.
Oh yeah, we've had a real blossoming
And-
of COVID in this county. It's really
Yes.
spiked, and I'm just.
And
starting
remember
in
now that R0 was 1.8 for the original COVID.
Now
It's
it's
6.6
Oh,
now.
it's 6.6. Yeah.
6.6. So
Which,
I mean, one
which
person
how
affects six.
contagious this brand
It is. But the treatments and what we have, people are surviving.
Well, some of the
still.
people at this table went down and got infused down and
Yeah.
had to drive all the way to Cherokee County or
Right.
somewhere and got to
They
get
had
the
a good
money.
they had a good doctor friend, and they got the Regeneron, and that's my point about being connected. Know what your options are. Know what your symptoms are. Reach out soon and quick, and get connected to someone who manages this. Okay, that's the way through. That's our way going forward. Don't be afraid. Go on with your life, and if you're in the high risk group, be more connected.
If you've got cancer, you
Yeah.
want to call Northside Cancer Center, right?
Yeah.
Yes.
Okay, if you got a urinary tract infection, you want to call your PCP, right?
Right.
You want to know who you're supposed to call for what. Who you're supposed to call if you've got the sniffles or a cough or a cold symptom today.
Not Ghostbusters.
No, who are you supposed to call? Your PCP, your primary care physician. You're not supposed to.
Ghostbusters.
Not Ghostbusters.
You're not supposed to call the public health department. They can't help you.
Right.
You're not supposed to call 911, get taken to the ER. That's the last place you want to go. You call your family doc. I'm home today. I'm blowing my nose. I got diarrhea or something, and then he's going to ask you, you had the vaccine? Did you eat at the Mexican restaurant last night? He's got a bunch of questions he's going to ask you.
And let me add one other thing to that. If you are advanced enough to feel competent at doing a test or a home test, get a couple of sets of home tests at your home. And you get those symptoms, call your doctor. You'll say, do the test, and you right then, within 15 minutes, we'll know.
Well,
So-
now, the accuracy of that test, though, is...
But it is helpful when it's
helpful.
positive.
Yeah. If it's positive, you know something.
I said that's
if it's
kind of an
negative,
iffy
you do it.
thing.
If it's negative, you do 1, 2, or 3 tests in a row. But if you still say sick, go let the doctor do a PCR test on you.
A full PCR, or they send you to where you can get one. But that's a hell of a lot better than wearing a mask. Anyway,
Got it. Is
Got
that
it.
your final word?
That's my final word.
final word.
Donate blood. 12 Marines, 13 Marines. One of them a Navy Marine got wounded yesterday. People need blood.
Okay, folks, Ask the Doc with Dr. William Whaley here, and Dr. Raymond Tidman, Georgia Cancer Specialist affiliated with Northside Hospital. We thank you so much for your questions. Don't forget, share this with your family and friends. Go to fyntv.com. We have an all-star political panel over here waiting, and we have our pet of the week. Now, Leo had to leave. Did Leo get in trouble?
Leo got in trouble.
Leo got in trouble. He had to leave. He just,
He was panting into the microphone.
yes, can't have that. Not on Ask the Doc.
One,
Folks,
one other thing. Bill started with this. I want to close with this. A terrible evil is happening in this world. Everybody needs to be praying about it.
I agree. Thank
I do
you.
too.
We'll be right back after these messages with our all-star political panel.